You have. It's the Independent Mental Health Advocacy Service, which I think most people might be aware of.
Yeah, absolutely. So it's so nice. Thank you so much for spending some time with us today. I think this is a really significant topic, and particularly now more than ever. So I'm wondering, so are you happy just to present some of your ideas? Yeah. Okay, fantastic.
Yeah.
We'll catch up with questions after we finish. Is that okay?
Yeah, of course. And I'm happy to. I have got a slideshow. I can use that, but I'll try and not talk at you for too long, so you've got time to ask me questions. And I'm actually going to skip quite a bit of the presentation just to give you some context around that, because I'm also starting from an assumption many of you know who IMHA is, but obviously if you've got questions about that, we could do that at the end as well.
Fantastic.
So I'll try sharing my screen. Oh, I can't share my screen. The host is disabled participant screen sharing.
Yeah, well, we're working on that. Yeah.
Oh, that's all right. That's all right. I can just talk to it as well. I might just start by acknowledging the traditional custodians of the land on which I'm currently on, which is the Wurundjeri people of the Kulin Nations, and pay my respects to elders past and present. Acknowledging sovereignty was never ceded, always was, always will be Aboriginal land. And I'd like to extend my respect to any community members present here today. I think also, given who I'm talking to, I just want to obviously acknowledge as well the lived and living experience in the room and of being carers and the important role that you play in consumers' lives. So I'll see if I can, I can share my screen now. So I'll just make sure it's the correct screen, because I get this wrong every time I do it. Can you see my screen now? Because
yeah, we can.
I can't see anything. Okay. So I won't go through these, but just if you're not aware, but the Mental Health and Wellbeing Act, I've put them in, actually now includes specific reference to Aboriginal and Torres Strait Islander communities, which I think is really important. So it's got obviously acknowledgement of treaty and statement of recognition. Oh, sorry. So I already said what I was going to do, which is talk a little bit about IMHA, but mostly talk about the non-legal advocacy opt-out provisions that have been added to the new Act. So IMHA, very briefly, is a free statewide non-legal advocacy service for consumers. It was funded by the Department at the time of Health and Human Services, and it came in as part of the reforms, the Mental Health Act 2014. People who do know of us will know that we work with consumers to understand and exercise their rights under the Act, and we do that in a range of ways, which is explained there. In terms of working with people's birth or chosen family, carers, supporters, and or king, that is by consent from the consumer. We do have people, carers and supporters calling us and family members calling our intake line and asking questions about what we do, also referring loved ones to us, and so long as the loved one is aware of that and they've got consent, that's fine. We will follow up. Otherwise, we talk to people about how to have that conversation with the consumer and what supports they might need, because often carers, families and supporters are calling us and talking about the also the support they need in terms of what it means to actually be a family carer and supporter of someone who's experienced mental health issues, and we make referrals for people and provide information as well if we can do that. So we provide the direct advocacy, but we also do information sessions, right talks, and support decision making training, and obviously a key part of my role is systemic advocacy. So that's actually working with services as well as with safeguard and oversight bodies around identifying what we're seeing in services and raising that at a systems level to try and get that addressed, rather than just being about the individual work we're doing, which is very important, but often what Tandem does as well, which is actually talking about what's going wrong in the system and what needs to change. This is a bit about my model, our model, which I won't go into because I won't have time. This is just to give you an idea of what IMHA currently looks like. So we've got 4 teams at the moment, Bendigo, Geelong, Dandenong and Melbourne. Those teams have advocates and senior advocate, which is a team leader role. And then they basically outreach to all the designated mental health services in their particular catchment. You can imagine with 4 teams in a whole state, this has meant that we have not been able to obviously see probably most consumers because of the fact that we don't have resources. We're only present in hospitals 1 day a fortnight usually, and unfortunately for places such as Mildura, which are covered by Bendigo office, they get a service once every 4 to 6 weeks of us in person. We are doing, actually now we're doing virtual outposts in many regional services who've been organised enough to allow us to do that in between going out there in person. Once we expand to deal with the opt-out and what that will mean, which I'll explain in a minute, I will have an additional 5 teams which are sitting in VLA offices across the state, and it means we're closer to the actual hospitals and the community clinics, so we can actually be present far more often in those areas. So we had an evaluation. We've got lots of resources on our website if people wanted to have a look. I've had feedback from several families and carers and supporters too that it's been useful even for them, not just consumers, as well as for clinical staff actually. It's been useful in terms of understanding what was the old Act, but will be updated for the new Mental Health and Wellbeing Act for people if they want to go in there, probably close to the 1st of September when those resources will be updated. So what's changing? So it's becoming an opt-out non-legal advocacy service. It was a recommendation 56 of the Royal Commission, and we have not yet been announced as the provider. That will happen today by the department. So we will continue in our role and be the primary non-legal advocacy service provider. We will also be responsible for maintaining a register, an opt-out register. So what does that mean? That means that we will now be receiving, not sure how yet, but from the Department of Health, we'll be receiving emails, encrypted emails with certain amount of information about consumers who experienced a range of different types of events in the mental health service. I don't actually think I've got a table about that, but basically those events look like there's 17 of them. Mostly they apply to people being placed on compulsory treatment orders of a particular type, not assessment orders, but temporary treatment orders and treatment orders. And then if people are subject to restraint or seclusion, and if they've got a hearing, and there's a range of other ones. 9 of those notification points actually apply to forensic and security patients. So they don't actually apply to most of the consumers that we see. And we'll be getting that information on a daily basis from services. So they enter it into their CMI system, and then it goes through a process and comes to us in a way that protects people's privacy. It will mean that we will call everyone and attempt to communicate with those consumers and offer them our service. And at that point, people can opt out. That's what the opt-out register is. We're going to keep numbers of people who decide not to actually opt into a service. So people can opt out for good. They don't want to have contact with us. We tick a box. We will never see their notifications again to protect their privacy, but they can opt back in. They can call us and opt in at any point in the future. Other people will opt in and want just the intake initial service, and other people will actually want the advocacy service, actually working with an advocate. And that will be something that we put out to the teams that are sitting locally and responding to services. In terms of our role, I don't know if people want me to go through this, but I want to leave time for questions, but it hasn't changed. So if people know what we currently do, it will remain the same in terms of providing information to an education for consumers and the community more broadly about our role and how we work within the principles, how we contribute in terms of being a safeguard, as well as looking at other overall relevant acts like the Charter of Human Rights and Responsibilities. This is the actual.
Sorry, this is Marie.
Yeah, you can ask.
And we're getting a few requests as to whether we can share these slides with.
Yes, I will. Yeah, I'll send them. Yeah, I'll send them to you. So the role, as I said, is the same as it was. Maybe just a glimpse if you can see those, but I'll send them to you. Some of the things maybe people aren't aware we do, because sometimes this comes up still, is that we can do advanced statement of preferences for people, currently called advanced statement, and we can actually support them to not actually nominate a support person as well. So we can do that paperwork with people if that's what they want. We do lots of referrals, which is a large part of the role, and obviously we attend meetings with consumers or we communicate with clinical treating teams if that's what they want. One of the key changes, we currently do work with children. I don't think that's very well known either, probably. The youngest children we've worked with have been 9 8-year-olds, but at this point, before the Act comes into place, I've got a practice guide, which actually guides staff, and actually only my senior staff work with children and young people because it requires working with families, and the senior advocates have that experience of working with families as well as with children and young people. But with the new Act, that actually is specified as one of the roles we have, and it looks a little bit different because it talks about 15 years and younger, and it has both a component of doing representational advocacy. So we only advocate based on what a consumer has wanted us to advocate on. There's no best interest. We don't do any assessments. And that will continue for children and young people. However, it also requires us to work with family carers and supporters to ensure that the consumer's best interests are protected. Whilst we have been doing that, it's never been in legislation. We will continue to do work relationally with families, carers, and supporters. That's the model. It's the same with working with families and carers and supporters, but it is an important thing that's been acknowledged in the actual legislation. And I'm keen to hear, not just now, because we probably won't have that much time, about how people see that working, or once we're up and running, and if you get feedback or you've had contact with us, for us to get feedback about how that's actually working in practice when we're working with children and young people, because the numbers of children and young people we currently see are small, representative of the overall number of percentage of children and young people who are in the system, but it's small because people have to find out about us, and that's mostly been via parents contacting us rather than services referring. So I think that's, I think that's probably one of the key things that I want to highlight here. And obviously, we have to do it in accordance with protocols, which the department is responsible for. And I don't believe they've started them at this point in time. I have raised it, and Marie might want to raise it as well, but I'm not aware of them having actually started that work. And obviously it will involve working with the FFH staff where there is child protection and particularly order in place to the Secretary. What we can do, so one of the things that probably has changed and is probably important, this won't apply to actually children and young people who are under 16, because parents, families, carers and supporters will obviously be involved. But for people who can't actually give us instructions and direct us around their advocacy, we'll be able to do a range of things, which include attend the Designated Mental Health Service, to actually meet with them. We'll be able to obtain information from the Designated Mental Health Service about what the person might have expressed around what their will and preferences are, if they've got an advanced statement, a nominated contact, nominated person, be able to liaise with the nominated person and represent people's likely views and preferences. I just want to be clear about this one, so because it comes up quite a bit. IMHA's been around since 2015, so it's about 8 years. We've never had a consumer that couldn't give us instructions about what they wanted us to do ever, because a key part of our role is actually to support people to make decisions. And so what we've often done is when people can't give us instructions is worked with them over a period of time. We've had actually a consumer where we worked with them for, and this is unusual, for a couple of months to support them to actually be able to communicate with us about what it was they wanted. And that's a key part. I'm as a support decision-making mechanism, but that's how we also work. We support people to make decisions if they need it. So I feel like this provision won't be used much, but the reason it's been put in there, I just wanted people to be aware, but you might be more aware than I am because we don't see everybody, is because some consumers who were consulted by Dr. Chris Maley when he did a piece of work for the department and made recommendations about recommendation 56, raised the fact that they were aware of small number of consumers and a particular consumer who was in a coma, who was having ECT, and that was why they wanted this particular provision put in there, so that people who couldn't actually communicate and might not be able to be supported to communicate for a period of time actually had an advocate, somebody who could potentially try and express what they we think they might have wanted. So that's one of the things that probably is important to highlight as well, and that you might have particular thoughts on or comments or questions. I think I've got 30 minutes and I think it's 11:15, so I will just maybe skip. These are the notification points because I was trying to remember them and I couldn't, and as I said, it'll be sent to you so you'll be able to see them in detail. what is new, I've touched on this, the fact that we get additional teams in VLA offices, which are closer to the services. I talked about child and youth advocates. The other thing I didn't mention, which is really important, is First Nations advocates. So we will have First Nation advocate roles for the first time, just in terms of being clear and, in terms of being ethical. This was a decision put to VALS, the Victorian Aboriginal Legal Service, about whether they would like to provide this non-legal advocacy service to their communities, or whether they wanted IMHA to do it. They've decided that IMHA should do it. And so we're working closely with them and our First Nations services internally to VLA. We've actually got Aboriginal community engagement officers and a director of Aboriginal services. So we're working with them around what that will look like in terms of those particular roles. Another critical thing, which I hope will be something that you will also be happy about, is that we will operate on Saturday and Sunday, which is not something we've done before. It's only been a Monday to Friday service. We'll actually work Monday to Sunday, 9:30 to 4:30. And we'll continue to receive phone calls from family carers and supporters, people at risk. So anybody who falls outside of that notification system, people who we will become aware of, can still contact us, and we'll still provide them with an actual intake service. That won't change, but it will at least mean we're available Saturday and Sunday for people as well, because I know there's not much available on the weekends for people, particularly for people to understand the system and their rights in that system. That's it from me. Sorry, I do talk fast as well, and I could not monitor the chat also at the same time, so I'll just stop sharing my screen if I can work it out, and yeah, that you ask me questions while I do that.
Sure. Thanks, Helen. There was a lot of information there, and lots is happening, obviously, in your area, and lots of and there's been some questions in the chat. So maybe if we could just check the chat and maybe
There you go.
Yeah. So, do you want me to read them out? I think
Tim will just take you to the very first question,
okay,
so that you can.
Yeah, I think it was Judy somewhere there. Yeah, Helen, can you please outline the reasons that individuals might opt out or are likely to choose to do so?
Okay, so we don't know actually about this, because a part of our external evaluation, which happened a few years ago, actually involved 40 consumers who had never heard of IMHA or used IMHA, and 60 who had used IMHA. And the 40 consumers spoke about the fact that they wanted to know about us. Why didn't they know about us? They don't care. They wanted an opt-out. They wanted to be contacted by us, because it otherwise relies on staff or people seeing information around the place, or meeting an advocate in a unit. So I don't know. We do know there's a particular group of people that might come for carers and families and supporters too, who've also got a lived experience of mental health issues. I know there's probably a small group of people who will utilise the systems we're going to put in place as the 1st of August to opt out before this starts. And the reason for that will be is because they might be my staff, VLA staff, VMIAC staff, consumer carer consultants in services, people that I suppose they feel that we might come across them in their work environment. They don't want us to know that they're actually being subjected to any of this. So I think there will be a small group of people that fit that particular thing. I think the other group actually is what I'm keen for us to learn I mean, you might have some ideas about that, but yeah, I don't really know what the other groups will be. I think we will definitely have people, because they can't really access us, who call us just to get an intake service. We actually provide coaching for self-advocacy, and people are happy to go off and talk for themselves with clinical treating teams. They don't want an allocated advocate. They just wanted that particular, brief service from us, and that will continue, I imagine. And they might say to us, opt me out, I'll call back whenever I want to. Or they might say, don't call me again unless you are notified that I am restrained. That's the only time I would like you to call me again. So people will have some control over also future contact and what that looks like.
Yeah, well, that makes absolute sense, doesn't it? That's fantastic. Okay, Judy also was asking, one issue that some carers have difficulty in setting is how to look after their loved one when the carer can't. What's going to happen if the carer or the family member can't look after them. So in what way can IMHA be formally nominated to assist the consumer as executor or co-executor for wills?
Oh yeah, I see what you mean. No, actually, so that doesn't change the existing legislation, the Guardianship and Administration Act, or Child Protection System for under 17s. No, we won't be able to do that role. That will remain a role of the existing services, OPA, and so if that's what was meant there, advanced, we can support people to do advanced statements, so that is perfectly fine. We can do that. We can support them to actually nominate somebody else as a nominated person if they have other people in their lives, if family can't do that. Yes, of course, they're the types of things we can do. And we will make referrals as well for people. If someone does need to do a will, for example, or wants to do an advanced medical, like a medical directive as well, we can refer people to services that can do that. Or to, so the other thing, just so people know, is that we do link people in who might have other particular areas of advocacy need which aren't related to mental health with other advocacy services. There aren't a lot of them, but if you've got particular things, there are, like, for example, older people, young people who've got disabilities, mental health is considered within that definition of disability. They have actually an advocacy service, so we will link people in as well.
Okay. Fantastic. That's a great explanation. Sarah's asking, how long will IMHA expanded capacity, last for, in a sense?
Oh, so this is actually an ongoing change. So we will expand, and the funding we receive from the department is ongoing. So until, I suppose, I think, I think IMHA's probably been quite, VLA has been probably quite verbal about this, but I suppose until the system continues using compulsory treatment, we will continue to exist as we are. I think there's, VMAC will say this, and maybe Tandem you would as well. There's a need for, I know carers, families and supporters have raised the need for their own support and advocacy, but also voluntary consumers who aren't considered at risk. And by at risk, I mean the person thinks that they might be placed on an order or they're being coerced. We can see them as well. But people who are voluntary, have also raised that they feel like they need an advocacy service. We don't cover that. We will, we have at times done some advocacy. It might be important for you to know this part. My intake team has at times done advocacy for people who've called who have been suicidal, who are in emergency departments, and the service is refusing to admit them. And they've, that's what they feel they need. We have advocated for people to be admitted. That's very unusual for IMHA to do. And the reason why I'm raising with you is that maybe if you have a loved one and that comes up, you could call the intake team. We might be able to give information. We might be able to do something. It'll depend. But I think we have tried to be a bit flexible, particularly about those situations, which are, really people are, it's crying out for help. And so, and haven't been able to get that, and they're in the service, we will try.
Fantastic. Another question is from Rao, I think, is you don't have an office in the Ballarat, which is another major region, Ballarat and Grampians region. Are you still able to service these areas in some way?
I should explain, sorry, because when you look at the offices, it looks like we don't do anything else. So currently Bendigo, the Bendigo team covers Ballarat and the Grampians region. And so that advocate goes out into the inpatient units fortnightly and does virtual outposts as well. But we will be so Bendigo actually will, so Bendigo currently, just to give you an example, Bendigo currently covers the Ballarat Grampians region. They cover Bendigo, they cover Mildura, they cover Shepparton and Albury Wodonga, and I've got 3 staff. So they are very stretched. What will change is that team will actually significantly grow, and what will happen is Bendigo will only cover Ballarat and Bendigo. We are leaving Mildura there. And they will have, 5 staff to do that. So they will be very much, much more present in that Ballarat region. And also they can sit the VLA office in Ballarat if they go out there and they're not sitting in the service, but they're providing services. They can go out and sit there, or they could be living there and they might be based there, but still be kind of supported and supervised by the Bendigo senior advocate. So and that applies to all the areas that you're seeing, all the offices you see. We will continue, like Frankston will go out to Latrobe. At the moment, it's Dandenong going out to Frankston and Latrobe. That's just, to give you an indication of what we've been trying to do over the past 8 years with the resources we've got.
It's an enormous area to cover. That's really good to know. I just wanted to also note, someone noted that you're speaking very clearly, so it's really getting through. So that's great. So can IMHA assist with voluntary treatments, or is it just compulsory treatment?
It's people at risk of compulsory treatment is the only voluntary group. But as I said, there's that small group that I said where if people, if it's people, sitting in ED room saying they're not going to be admitted, who are, feeling like they're at a crisis point, we might be able, it's always worth, people can call us. We've got a lot of self-advocacy resources too. So for people who that is something that's accessible, it's not accessible for everybody, there's actually some tools we have that we can also talk people through, even if we can't do it, that we can actually provide them with, a range of information, link them to the website, and also link them to other services that might be able to do this work, like VMIAC. Actually, I should have said that one of the things that will also happen is that we will offer IMHA for people who opt out and say, I don't want you, we can actually offer VMIAC as an alternative provider. So if people say no, so it won't be that VMIAC can scale up to this extent. We are the primary provider, we're scaling up, but it does mean for a group of people who say no to us, we can offer them VMIAC. Yeah.
So they've got a bit of a choice. That's
great. It gives and that's why it happened that way, as well as some choice around First Nations advocates as well. And,
absolutely. Okay. And the final question, will IMHA involve carers when the consumer has like dual disabilities and particularly difficult in communicating?
Yeah, so if there are people involved in the consumer's life, it's really about, for us, it's about the fact the consumer needs to consent for us to be doing that. And where we've had consumers who've had families and supporters involved, they've come to meetings with us. We've actually, it's unusual, we've had a time where the primary person we were talking to was the consumer's family member because of the consumer's difficulty in communicating over the phone. I mean, we do put measures in place to make sure that we're constantly also speaking to the consumer, or at least relaying the information that's been agreed to and what actions have been taken. But yes, we will work with consumers and supporters and carers in terms of communication, where they understand that that's what we've been doing. I suppose, just so you know, with children, regardless of, some have had disabilities, other disabilities, or being on the neurodiverse, but even for children broadly, parents are always involved in that process. But also we ask parents about how it is like the developmental stages of a child in terms of age, but what is it their child prefers to communicate, what types of things are they into, so ways that we can build rapport with the child as well. So we will speak to family about that.
Okay, fantastic. Look, there's no more questions. I think it's great people are putting the questions in the chat more so than trying to kind of capture your hand. So that I really appreciate it. Oh, there is one here. One more. Graham has a question for you, Helen.
Hi, Helen. Graham George here. Thanks for your presentation. Look, I was just wanted to ask, you're talking about what you can do to support families and carers with the consumer's consent. Within the legislation, what options have you got for supporting carers and family if the consumer won't consent or explicitly says, I don't want you contacting my family?
Yeah, so I think, Graham, at the moment, I don't think the new act will change that. We would still be getting consent from the consumer. The service was co-designed with consumers. There was carer involvement as well. We have to get that looked at in terms of the Mental Health Act, so we will look a little bit more into it, just so we do the right thing and make sure we're not missing anything. But at this point in time, it will require the consumers consent to work with family and carers, and that has changed at times too. For people, it's not a one conversation with consumers and carers. Sometimes they will say no at the beginning, but then after, they actually want someone to be brought in to the to support them. We've also had consumers and carers. So I've even, when I've done advocacy, which is rare, but I've worked with I worked with a consumer whose mum was coming to the treating team meeting. The consumer, they were both present to the service. This is pre-COVID, and I went in. I asked the consumer whether I could speak to his mum. His mum was there. She came in and joined us. She had very different preferences to the consumer. We talked about that openly. I talked about my role, and I would obviously support the consumer and, give voice to what he was wanting. And that, I told his mum her rights to be able to be heard as well. And that if she, didn't feel that was happening, she could also look at me in a particular way, and I could remind the clinical treating team, but we do need consent. But we'll look at that, Graham, a bit more in terms of the Act, and if there's anything that actually changes that with this Act.
Can I just sort of, on that theme, what about situations where can carers approach IMHA if they are having issues with the service and the consumers are supportive or neutral, or?
So when consumers have been supportive, we have actually advocated for carers. Like, for example, people were refused to have a family member in a clinical treating team, and the consumer wanted us to advocate for that person to be present. So we advocated. That's what obviously the family member wanted as well. But I mean, you can contact us. We can't do advocacy that doesn't relate to the consumer's instructions. I think that's the difficulty. What we would be doing is probably giving information and, you know, referring you out to where you might be able to get your own advocacy if that's what you need. Noting that I know there's not a lot of options, but Tandem, I don't know about the carer hubs. You are the point at which we refer families to. So yeah, but you know, you can reach out.
And Helen, we have good referral pathways together.
Yeah, we do.
Thank you very much, Helen.
Yeah. And we've really appreciated that's been really important for us, and hopefully you have as well. But as I said, I'm very open. If people have got other questions, you can email me. I'll send you the presentation. If you've got particular thoughts after you look at it about things that you think we should consider, if generally, but in the child and youth space, please feel free to email me, contact me. I'm more than happy to have this conversation, or tell Marie. Marie and I meet monthly, we do monthly regularly, so we can also have those chats as well.
Yeah,
and sorry, I should have said Marie will be on our interview panel for the child and youth advocate roles. She's also looked at the position description. Sorry, I missed that bit, but that was important.
Fantastic. Oh, well, that last bit was really good to know that you have this connection with Tandem. I think that makes
we do.
a lot of difference. So thank you, Helen. That was just wonderfully presented, and I think this information is so vital. It's such a difficult and you know, disputed area, and to hear your views of it is really, I think, quite reassuring. So, and knowing the limits of what we can do and what we can't do. So thank you so much, Helen. I should let you go.
You're very welcome.
Thank you.
Thank you, everyone. Enjoy the rest of your day.